So I'm going to talk more about the molecular side of sudden cardiac death, following on from Stathis' clinical elements. Okay, so the causes of sudden cardiac death have been covered this morning, but we broadly divide those into structural causes and arrhythmogenic causes, or SADs. And those with structural causes typically are identified at the post-mortem, whereas the arrhythmogenic causes have a negative post-mortem. The molecular autopsy attempts to then determine the cause of death in those who have the negative post-mortem. And essentially, it's a bit of a CSI-type approach where we extract DNA from the deceased, and then using PCR, we are able to sequence and potentially find the cause of death in the individual. So we tend to follow this flowchart whereby if the heart is structurally normal, which is approximately 40% of sudden deaths, then we suspect an inherited arrhythmia syndrome and we can proceed to molecular autopsy. And the classic molecular autopsy covers the 4 genes for the main inherited arrhythmia syndromes, Brugada, LongQT, and CPVT. It's important if we're talking about genetic testing to acknowledge that genetic testing is no longer a binary yes-no answer, and we now discuss genetic testing on a spectrum from benign to pathogenic. Mutations that are graded beyond VUS only, such as likely pathogenic or pathogenic mutations, are able to be used in predictive genetic testing in first-degree family members, therefore determining if they are also at risk of arrhythmias that has affected the sudden death of their first-degree family member. This is a study from my group in Sydney, and we've heard a small amount of data from this study this morning. But the most important point about this study is that it's prospective, and really this is a collaborative effort across Australia, and it was a big undertaking whereby we basically got all the coroners in the big cities in Australia and New Zealand on board. And the unique part of this study is that we actually had the denominator for the first time. And we showed that 40% of sudden deaths were unexplained. And interestingly, more than half of these deaths actually occurred during sleep. We then proceeded to molecular autopsy of these individuals and found 20% clinically relevant gene mutation in 113 cases of the sudden deaths who we were able to sequence. In terms of the genetic testing that was performed in the sudden death cohort, the 113, it was a number of different approaches, and this is really a reflection of the time that this study was performed with the recruitment from 2010 to 2012. ACMG criteria was just coming in soon after this. But actually, really what we were doing was actually covering ACMG criteria before it was formalised. And basically looking at a number of different sequencing modalities, but ultimately all individuals had a minimum of 59 channelopathy and cardiomyopathy genes covered by a variety of approaches. And when we looked at basically pathogenicity to determine causality, as I said, we did really look at ACMG type criteria, although it wasn't formalised at the time, basically looking at whether it had been previously reported in the literature and then the effect of the mutation on the protein. Looking then at the GERP score, which is a score basically looking at how much it affects the protein also. And then some basic in silico predictive tools, which really, again, use computational modelling to essentially help determine whether we think this is pathogenic. And there was some data at the time to suggest that more than 2, correlation between more than 2 of the in silico programs was sufficient, and that's now been incorporated into the ACMG criteria. And through this, we then determined the pathogenicity of the variants. And as I said, with this pipeline, we were able to identify 31 clinically relevant cardiac gene mutations, so giving an answer to a number of family members that would otherwise have not known the cause of death in their family. Importantly, in this study, molecular autopsy for genes did account for about 25%, but also other cardiac arrhythmia genes and other cardiomyopathy genes were included in the subsequent kind of pathogenic and likely pathogenic yield. A similar study was also performed by the group at George's that I now work in, looking at post-mortem genetic testing in SADS. And this is in a slightly smaller cohort of 300 individuals, but the demographics are very similar. You can see here that, again, the proportion of these deaths were really in sleep and in individuals with no prior symptoms. They showed a lower yield in their molecular autopsy with a 13% yield of pathogenic or likely pathogenic variants. Some important differences with this study is that they used more stringent variant calling of 1 in 10,000 minor allele frequency. So this refers to how common these gene mutations are in the general population, using large general population data sets so they're freely available on the internet. They had a high proportion of RYR2 variants and CPVT. In this particular cohort, which was not seen in the Australian study. And as Stathis talked about earlier, and a lot of these families are also in the study he was presenting, and by combining clinical evaluation with molecular autopsy, the yield is increased to 39%. They did use ACMG criteria in this study and basically showed that with regards to primary electrical disorder, there was a good yield of pathogenic and likely pathogenic variants. Unfortunately, with cardiomyopathy genes, we're seeing many, many more variants of uncertain significance, and these are not clinically useful, and really, I guess, one of the criticisms of molecular autopsy, because we cannot extrapolate this to family members. So why do we find variants in cardiomyopathy-associated genes in autopsy-negative sudden cardiac death cases? Well, it may be that there's subclinical cardiomyopathic changes that may have been missed at autopsy. May be non-diagnostic minor pathological changes. There may be some cardiomyopathy variants can be arrhythmic before the onset of cardiomyopathy, and we know this happens, for example, in TMEM43, a highly malignant arrhythmogenic cardiomyopathy gene seen largely in a founder population in Canada. The cardiomyopathy genes are very large, so sequencing them is a challenge, but also, obviously, the larger the gene, the more chance you're going to have of finding variants of uncertain significance. And of course, there's always the chance that these variants are not important. They're simply innocent bystanders. So what about other options for post-mortem diagnosis beyond the molecular autopsy and clinical screening? So this is a small study that we performed in Sydney as an offshoot of the New England Journal paper, where we actually looked at comparing conventional autopsy with MRI. And we did MRIs within 24 hours of of people dying, if we were able. And obviously this was a challenging study to perform, but nonetheless we got a reasonable cohort here of 17 individuals who were able to undergo imaging prior to their post-mortem. And 71% males and average age of 22. We did cardiac and brain MRIs. And important to acknowledge that not all of these sudden deaths are cardiac, in fact. And the post-mortem CMR yielded a correct identification of the 12 cases who had abnormal post-mortem. So 5 of the deaths were unexplained, and they remained unexplained. We found high sensitivity with post-mortem CMR and a high negative predictive value, 100%, and an excellent positive predictive value of 80%. So the real utility of this, people say, well, why wouldn't you just do an autopsy? But we see that this really could be useful in particular religious groups, for example, where it's mandated that the deceased is buried within 24 hours, and performing a comprehensive autopsy is not always possible in that situation. And this often provides the cause of death. Just some pretty pictures to show how we correlated the imaging findings with post-mortem. So these are the 4 cases of ARVC, and the imaging findings here showing that in the ARVC individuals, we had an RV to LV ratio greater than 2 as a kind of cutoff to help diagnose post-mortem ARVC. There was a single outlier here, which was one of the false positives. So all ARVC cases were correctly identified on CMR, and we proposed a cutoff of RV-LV ratio greater than 2. Just a few other pretty pictures. So we correctly diagnosed post-mortem hypertrophic cardiomyopathy, and you can see here classic asymmetrical septal hypertrophy. Obviously, I'm sure everyone's picked it up, but there's The lines here are because, of course, these individuals are deceased, and so there's a water level of the blood pool in the heart. Here we have a myocardial infarction and clear lumen obstruction by the thrombus at the subsequent post-mortem, and myocarditis picked up by some increased edema here on the post-mortem CMR. We also picked up some non-cardiac causes, vascular causes and neurological causes. So here we have an aortic dissection causing hemopericardium, and we also have a massive saddle PE here causing sudden death in a young individual. Finally, a very large brain tumour, and this is actually sudden unexplained death in epilepsy with some edema of the hippocampus, which is classic of this particular condition, of which I'm not an expert in. Finally, I'd just like to present a case from our clinic to just kind of highlight the challenges of post-mortem genetic testing and what can go wrong if you go far down the path. So we had a family, Mrs. LB and the B family, referred by the coroners after the sudden death of the son, aged 22. So this is the young boy who died, and we initially did clinical screening of all first-degree family members, so SIBs and parents, and he was found to have ARVC at post-mortem, and in fact he was in that study, and he was also found to have ARVC at CMR, as we've just heard. And so clinical screening of his family members revealed that his brother also had ARVC, and his mother actually had a Brugada syndrome phenotype, which we do see a crossover between Brugada and ARVC clinically. Proceeded to molecular autopsy in the decedent, and we found a likely benign mutation in DSP. DSP is an ARVC gene, but this is a benign mutation. And we also found a likely pathogenic mutation in KCNE1, long QT gene 5. Then, proceeding to genetic screening in the parents, found that the dad, who's clinically unaffected with either ARVC or long QT syndrome, has in fact got the benign variant, but also got the pathogenic variant in long QT5. Mum has neither. The brother, who has ARVC, also carries neither of these gene mutations, but he also has ARVC. He does not have long QT syndrome, and the DSP variant is benign. We then double-checked and did exercise testing and further testing in the family members to make sure that we did not miss any long QT cases, and in fact no one in this family has a long QT phenotype. So really the question is, has this molecular autopsy helped at all, or has it simply clouded the picture? And we should return back to clinical screening in this family and look for a phenotype of ARVC in first-degree family members. Further screening has revealed that the sister of the decedent has got the mutation of KCNE1, as does her child. But what does all of this mean? So we have a confirmed ARVC in a deceased, likely ARVC in a brother, a long QT variant but no long QT phenotype, a Brugada phenotype in the mother, and a benign arrhythmogenic cardiomyopathy variant. It's a mess. Remember, when you order any genetic testing, match the genotype to the phenotype. I'll just move quickly because I think I'm out of time, but this is hot off the press, accepted from my group in Sydney. I thought it was nice to present this in this audience, basically looking at psychological adaptation to molecular autopsy findings following sudden death. And Jodie Ingalls is a prolific researcher, genetic counsellor. And basically, her student has interviewed 33 first-degree family members of sudden death victims, providing genetic counselling and psychologically support, and using a validated system. The family members were graded as good or poor adapters to the genetic information. And the poor adapters were found to have a high prevalence of post-traumatic stress, depression, and found to have lower perceived support networks. So it's important to care for the family in a holistic approach, and we have a psychologist in our clinic in Sydney for that reason. Stathis has covered this, but just simply to say that in the guidelines, a molecular autopsy can be useful, and genetic screening of first-degree family members when you find a pathogenic mutation is recommended. So ensure expert pathology, whole heart and DNA retention. Ambiguous pathology is SADS until proven otherwise, clinical screening in first-degree family members. So in conclusion, molecular autopsy ready for prime time. My short answer is yes. It provides the family with an answer, and in combination with clinical screening, we can have an increased yield of 39% for these families. It obviously provides prognostic information in certain circumstances, such as in long QT type 2 or long QT type 3 provides therapeutic information where we can actually do genotype-directed therapy. If we find de novo ryanodine receptor variants in a deceased, then we know that that the siblings of the deceased are not at risk, and this provides a lot of reassurance to parents who have just lost their young child. But there are some caveats, of course. Match the genotype to the phenotype. It's very important that the genetic information is handled by people who understand it, and the variant interpretation is performed carefully. The oligogenic basis of some inherited arrhythmia syndromes is increasingly described, particularly Brugada syndrome. So that obviously makes molecular autopsy more challenging if it's not a single cause of disease. And so the importance of a specialised multidisciplinary clinic when performing molecular autopsy and psychological support cannot be underestimated. Thanks very much.